If you've been diagnosed with peritoneal mesothelioma and you're preparing for cytoreductive surgery with HIPEC, understanding what recovery in the hospital looks like will help you mentally prepare for what's ahead. This is major surgery followed by heated chemotherapy, and the immediate postoperative period is intense. Today, I want to walk you through what happens right after surgery, what the first days in the ICU and hospital are like, what tubes and equipment to expect, what complications to watch for, and when you can expect to go home. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a physician, and this is not medical advice. But knowing what to expect after HIPEC can reduce your anxiety and help you and your family prepare for the hospital stay. So let's start with what happens immediately after surgery. You'll wake up in the intensive care unit or ICU rather than in a regular hospital room. Everyone goes to ICU initially after cytoreductive surgery with HIPEC because it's considered a critical care operation requiring close monitoring. You'll be connected to multiple tubes, lines, and monitoring equipment, which can be alarming for family members who first see you. So let me explain what everything is and why it's there. You'll have an endotracheal tube. That's a breathing tube that goes through your mouth and is connected to a ventilator. You'll be on that for the first several hours to possibly overnight. It breathes for you while you wake up from anesthesia. Once you're awake and breathing adequately on your own, the breathing tube is removed, and that usually happens within 6 to 12 hours after surgery, though sometimes it takes longer. You'll have an arterial line. That's a small catheter in an artery in your wrist that provides continuous blood pressure monitoring and allows frequent blood draws without repeated needle sticks. This typically stays in for 1 to 2 days. A central venous catheter, which is a large IV in your neck or chest, provides IV access for medications and fluids and might stay in for several days to a week. Continuous pain medication goes directly into the spinal area through an epidural catheter in your back. It delivers excellent pain control and is one of the most important tools for managing postoperative pain. The epidural usually stays in for 3 to 5 days, then is removed, and you'll transition to oral pain medications. There will be multiple abdominal drains coming out of your abdomen. They drain fluid from the peritoneal cavity and are critical for monitoring for bleeding, infection, or anastomotic leaks. The drain output is measured carefully for color, amount, and character of the fluid, which all provide information about your recovery. They'll be removed one by one as output decreases, and that's typically over 5 to 10 days. Now I'm going to take a quick break to ask you, if you find these videos helpful, please hit the like and subscribe buttons. It makes it easier for other people who need this information to find us. And if you have questions or a topic you'd like to see addressed in a future video, drop me a note in the comments section. And make sure you watch until the end, because I'm going to give you valuable information on where to find resources that will make a real difference for you. Other tubes, a nasogastric or NG tube will run through your nose into your stomach. It decompresses the stomach and prevents nausea and vomiting while your intestines recover from surgery. It's probably the most uncomfortable tube, and it typically stays in for 3 to 7 days until your bowel function returns. A urinary catheter will drain urine and monitor your kidney function and stays in for several days and is usually removed around the same time as the epidural. There will be compression devices on your legs to prevent blood clots that inflate and deflate automatically, squeezing your legs to keep your blood moving. What does the first day or two in ICU involve? You'll be monitored continuously. Your heart rate, blood pressure, oxygen saturation, and your breathing rate. Nurses will be around constantly and blood is drawn frequently, sometimes every few hours at the start. This is to check for bleeding, kidney function, electrolyte levels, and other parameters. Pain control is a major focus. The epidural provides baseline pain relief, but you might need additional IV pain medications. Don't try to tough it out. Good pain control is essential for breathing deeply, coughing, and preventing pneumonia. You'll be encouraged to take deep breaths and use an incentive spirometer. It's a device that helps expand your lungs. Most people hate it, but using it is critical for preventing pneumonia and atelectasis, which is lung collapse. Physical therapy will generally start on day 1 or 2, and it'll involve getting you sitting up in a chair, even while you're still in the ICU. This early mobilization prevents complications. Fluid management is crucial. The HIPEC and surgery cause significant fluid shifts, so you're going to receive IV fluids that have been carefully calculated to maintain your blood pressure and kidney function without overloading you with fluid. Now, what are the potential complications to watch for? Bleeding is a risk in the first day or 2. Drains will be monitored for excessive bloody output, and if your bleeding is severe, you might need to return to the operating room. Infections, including pneumonia from being on the ventilator, wound infection, or intra-abdominal abscess, are all possible. Fever, elevated white blood cell count, or changes in drain output might indicate infection. Anastomotic leak. That's if intestinal connections were made during the surgery, they could leak in the first 5 to 7 days, and this can cause fever, abdominal pain, and changes in the character of what's seen in the drain output. Small leaks might heal with antibiotics and drains, but large leaks might require reoperation. Ileus, which is temporary paralysis of the intestines, is universal after this surgery. Your bowels may not work normally for 5 to 10 days. The NG tube prevents problems from this, and then your bowel function will gradually return. Kidney dysfunction from the surgery, fluid shifts, and heated cisplatin can occur. It's monitored closely with blood tests and urine output measurement. Most kidney problems are temporary and improve with hydration and time. Cardiac arrhythmias are irregular heart rhythms, and they can occur from surgical stress, and they're usually managed with medications. Respiratory failure, requiring prolonged ventilator support, is uncommon but possible, particularly in patients with pre-existing lung disease. So when do you transfer from the ICU to a regular floor? Typically, it takes about 2 to 4 days if your recovery is progressing well. The criteria for transfer include stable vital signs without needing ICU level monitoring, being off the ventilator and breathing well on your own, having your pain controlled with epidural and oral medications, there being no evidence of major complications, and demonstrating adequate kidney function and urine output. What does recovery on the regular floor involve? Once you're there, the focus is going to shift to getting your bowel function back and building your strength. The NG tube will be removed once you have bowel sounds and are passing gas. These are important signs that your intestines are waking up and typically happen around day 4 to day 7. You'll start taking in clear fluids, then advance to full liquids, then soft foods as tolerated. Abdominal drains will be removed one by one as your output decreases. The epidural will be removed, and you'll transition to oral pain medications. You'll work with physical therapy daily, walking progressively longer distances in the hallway. The goal is independent walking, eating regular food, having normal bowel movements, and having adequate pain control from oral medications before you're discharged. What's a typical hospital length of stay? For uncomplicated recovery, 7 to 14 days is typical. Some patients are ready for discharge in a week, others need 2 weeks or more. Complications can extend the stay significantly. If you develop an abscess requiring drainage, an anastomotic leak requiring antibiotics and drain management, or other issues, you could be hospitalized 3 to 4 weeks or longer. What happens at discharge? You'll be given detailed instructions about wound care, activity restrictions, including no heavy lifting over 10 to 15 pounds for 6 to 8 weeks, pain medication management, and signs of complications requiring medical attention. Follow-up appointments are scheduled with the surgeon, usually 2 to 3 weeks after discharge. You might go home with some drains still in place if they're still putting out fluid. These will be removed at follow-up appointments. Some patients need temporary home health nursing to help with drain care and medication management. To review, after HIPEC for peritoneal mesothelioma, you wake up in the ICU with a breathing tube that will generally be removed in 6 to 12 hours, an epidural for pain control, an arterial line, a central IV, 3 to 5 abdominal drains, an NG tube, a urinary catheter, and leg compression devices. The average ICU stay is 2 to 4 days with close monitoring for bleeding, infection, leaks, kidney dysfunction, and other complications. Then you'll be transferred to a regular floor and hospital room when you're stable. The NG tube will be removed when your bowel function returns, usually between days 4 and 7. The staff will be looking for progressive diet advancement and improvement in movement through physical therapy. Your drains will be removed as your output decreases. A typical hospital stay for this procedure is 7 to 14 days for an uncomplicated recovery, but longer if complications occur. You'll be ready for discharge when you're eating well, walking, and report adequate pain control on oral medications. You can visit mesothelioma.net for information about HIPEC and peritoneal mesothelioma surgery, or call us at 1-800-692-8608, or use the live chat feature on our website. That way you can work with one of our patient advocates right away. As for me, remember to post your questions below, and I'll see you next time.